Good afternoon, everyone. I'm Bernard Cheung. I am very this webinar, which is the first of a series of webinars on health inequalities during this World Health Life Week 2023. This webinar is held by the Healthy Heart Trust in partnership with the Fellowship of Postgraduate Medicine. We know that cardiovascular diseases and hypertension are strongly related to socioeconomic status and also to genetic factors. That includes, your ethnicity and race. And so it's very important in order to prevent cardiovascular disease to look at such factors because they really affect our risk of cardiovascular disease. So without further ado, I'd like to introduce our first speaker this evening, who is Dr. Shahed Ahmed. He's the National Clinical Director for Cardiovascular Disease Prevention at NHS England. And he's going to talk to us about race inequality and cardiovascular disease. So, Dr. Ahmed, please.
Thank you. So could I have my first slide, please? Thank you. Hello. So thank you. So as has been mentioned, my name is Shahed Ahmed. I work for NHS England, and I'm the National Clinical Director for Cardiovascular Disease Prevention. I've put my Twitter handle on the page here. So if you want to, you can see what I write about CVD prevention on there. Next slide, please. So what motivated me to be the NCD for cardiovascular disease prevention? I'm not a GP with a special interest in cardiology. I'm not a cardiologist. I'm somebody who wants to save lives and reduce health inequalities. And cardiovascular disease prevention is probably the best and fastest way to do that. For decades, all-cause mortality in this country had been falling steadily. And then about 10 to 15 years ago, it started to flatten off. And the reason it flattened off is because our improvements in cardiovascular mortality started to flatten off. So if we want to improve all-cause mortality, one of the best things we can do is cardiovascular disease prevention. Next slide, please. So those of you who've read NHS England's long-term plan will recognise this, and you'll see that cardiovascular disease is the greatest cause of the gap in life expectancy between the richest and poorest in society. Next slide, please. And there are huge ethnic differences in cardiovascular mortality. This is a slide produced by the King's Fund based on ONS data that shows big racial disparities in terms of mortality from cardiovascular causes. Next slide, please. And cardiovascular disease doesn't just cause death, it causes disability. So hypertension is one of the major causes of DALYs, disability adjusted life years. Next slide, please. So the slides I'm about to show you now, they're taken from the ONS's publication published on this website, where they published it just a few weeks ago, where they looked at mortality from leading causes of death by ethnic group in England and Wales from 2012 to 2019. Next slide, please. So, this is a little bit hard to read the detail, but you'll see that for males in all ethnic groups except Black Caribbean, the leading cause of death was ischemic heart disease. And you can see that in ethnic groups, many of the ethnic groups, the rates were much greater than the national average. Next slide, please. So for females in all ethnic groups other than Bangladeshi, Indian and Pakistani, the leading cause of death was dementia and Alzheimer's. But actually, if you do look at the Bangladeshi, Indian and Pakistani groups, you'll see that cardiovascular disease is a leading cause of death there. Next slide, please. And in males, the highest mortality rates from ischemic heart disease are in Bangladeshi, Pakistani and Indian ethnic groups. Next slide, please. In females, The highest mortality rates from heart disease are in Bangladeshi, Pakistani and Indian groups. Next slide, please. And similarly, for cerebrovascular disease. So, for both sexes, the Bangladeshi group had the highest rate of death from this cause. Next slide, please. So I'd really recommend this website if you haven't looked at it. It's a CVD Prevent website, www.cvdprevent.nhs.uk. It's one of the true privileges of my life to chair the CVD Prevent steering group. And over the past 3 years, we've produced some amazing stuff, and it's all available on a really usable, interactive website. If you go to CVD Prevent and you scroll down the page a little bit, you can hit on the regional and ICS insights tab, and you'll see a whole range of markers there. And if you hit on open indicator, you'll get graphs like this. And what this graph is showing us is the percentage of patients in whom the blood cholesterol is less than 2.5 millimoles per litre. And the different lines here are by different deprivation quintile. So you can cut this information by deprivation quintile, by ethnicity, by gender, or by learning disability. A really useful slide to use, a really useful website to use. Next slide, please. For all the reasons I've mentioned, that's why cardiovascular disease made it into NHS England's long-term plan. And we had ambitions for atrial fibrillation, for blood pressure, and for cholesterol. Next slide, please. And we've made great progress to date. So if we look at pre-pandemic figures versus March 23, we now have over 1 million people with atrial fibrillation treated on medication. That's more than 91,000 more than pre-pandemic. For blood pressure, we have 6.2 million people with their blood pressure treated to target. That's 175,000 more than pre-pandemic. And for lipid lowering therapy, we have over 1.5 million people with a high Q risk score now on lipid lowering therapy. That is more than 300,000 more than in 2021. So we've achieved some fantastic results since the start of the pandemic. Next slide, please. And this is my final slide on the topic. It's not just health service data that we have. There are other sectors that have brilliant data. So this is the Sport England Active Life survey, which shows that for ethnic groups, the rate of physical activity varies as well. And you'll see the patterns pretty much mirror the patterns of cardiovascular mortality. Next slide, please. So thank you for listening, and I hope that provides a good overview for the rest of your conversation today. Thank you.
Thank you very much indeed, Shahed. I think that really sets the scene very well for our topic today. I would like to remind our participants to type their questions into the Q&A function, and our speakers will answer your questions at the end of the 3 talks. So it's my pleasure to introduce the second talk, which is going to be given by Dr. Sophie Eastwood. She's a clinical epidemiologist in UCL's MRC unit of lifelong health and aging. And Sophie is going to talk to us about high blood pressure and control and how it varies by ethnic group in the UK. So I'd like to welcome Sophie to give us a talk on blood pressure and control. Sophie, please.
Thank you very much indeed for that introduction. Okay, you should be able to see my screen now, I think. Please let me know if
yes,
not.
we can.
Great. Okay, so yes, I'm going to talk about high blood pressure or hypertension treatment and control. And I thought I'd start off by just telling you a bit more about myself and my background. So I'm a GP by training, and shortly after I qualified in 2008, I went to work in a practice at the bottom of this tower block here, which is in an area called Somerstown, just north of Euston Station. And there were really big Somali and Bangladeshi populations there, quite deprived populations. And it was there I really began to notice really marked ethnic differences in health outcomes, and became motivated to do something about it. So this led me to go and do a master's degree at the London School of Hygiene and Tropical Medicine. And after that, I got a job working with Nish Chaturvedi on the SABRE study, which is a multi-ethnic cohort study focusing on diabetes and cardiovascular disease. And we noticed that our South Asian and African Caribbean participants seem to have much worse diabetes and hypertension control than the white European participants. And so a few years ago, I got some funding from Diabetes UK to study ethnic differences in diabetes and high blood pressure treatment in a large database of UK general practice records that's called CPRD. And that's the work that I'm mostly going to focus on today. There's a dotted line here because I'm hoping it's sort of going to lead back into practice. Okay, this is the outline of my talk. I'm going to start off with some background, reiterating some of Shahed's messages, I think, and then outline the aims of the study and the results, and then sort of try and interpret them for you. So, as you've heard already, there are some major differences in cardiovascular disease rates for the three largest ethnic groups in the UK. So both South Asian and African Caribbean groups share greatly elevated risks of diabetes and strokes when compared to people of white European ethnicity. And the South Asian population also have an increase of coronary disease, as Shahed said. But paradoxically, given their high prevalence of diabetes, which is a key risk factor for heart disease, our African Caribbean groups actually have lower risks of coronary heart disease in the UK. So high blood pressure or hypertension is a key medically modifiable, which means something we can treat, risk factor for strokes and coronary disease in all populations. And I think it's important to mention that treatment guidelines differ by ethnicity in the UK. So if you detect a patient with hypertension, you're supposed to treat people of Black African heritage with a drug class called calcium channel blockers first, whereas there's a different, or supposed to be a different first choice drug for people of European ethnicity under 55. And the rationale for this comes from the ALL-HAP trial, which was carried out in North America in the early 2000s, which showed that that class of drug, calcium channel blockers, is supposed to be more effective at preventing cardiovascular disease in Black than white populations in those countries. But I would like to mention that other trials and studies of real world evidence, which is the type of data that I'm going to talk about, haven't necessarily replicated these findings. So previously in the UK, there's been many studies comparing blood pressure control in people receiving treatment for high blood pressure or antihypertensive treatment. And overall, the consensus seems to be that blood pressure control is similar or better for people of South Asian and European ethnicity, but control in most studies is worse for African or African Caribbean groups. And I think it's worth saying that historically, people have offered sort of biological explanations for this, with people suggesting that populations of African heritage may have lower levels of a hormone called renin that's important in regulating blood pressure. But the thinking's changed a bit on this, and nowadays we're challenging those old assumptions, and the role of social factors, particularly those sort of related to the effects of structural racism, have been more widely recognised in the picture. But all of the studies so far which I've talked about, or most of them have been cross-sectional, so it's just a snapshot at one time point. We don't really get a picture of how hypertension is managed over a period. They've mostly been in databases of London general practices, so not nationally representative. Guidelines have changed since some of the studies were published. None of them that I'm aware of sought any explanations, and importantly, as you'll go on to see, none of them accounted for adherence. So that means how regularly people take their medication. My work over the past few years has aimed to investigate ethnic differences in detection of high blood pressure, initiation of treatment, subsequent management after treatment's been started, regularity of antihypertensive use, and importantly, obviously, blood pressure control after starting treatment. So let's move on to the results now. And these are some of the characteristics of the sample. So these are individuals from the database with at least one blood pressure exceeding a screening threshold for treatment during the study period. And obviously people who came into the study initially weren't receiving antihypertensive treatment. So we started off with a sample of about 800,000 people, and just to highlight some of the differences by ethnicity here. So the South Asian and African Caribbean groups were 6 and 8 years respectively younger than the European group. And the African or African Caribbean groups were more deprived. And you'll see that both South Asian and African Caribbean groups are much higher prevalence of diabetes, which will mostly be type 2 diabetes in these populations, than the European population, even though they're, at these young ages. However, blood pressure, starting blood pressure on entry to the study didn't differ greatly by ethnicity. And about 200,000 of these 800,000 went on to receive treatment. Sorry, just changing the slide. Right, so these were the main findings. I'm just going to walk you through the graph first, because it's a bit complicated at first glance. So the red dotted line represents the situation for the European groups, which we used, for better or for worse, really, as the comparator to the other two ethnic groups. The orange dots represent the ethnic difference between South Asian and European groups, with the caps lines around the dots showing how precise or otherwise our estimates of the ethnic differences were. So where the orange dots lie to the right of the line, that's where the outcome was more likely than for people of European ethnicity. And where the dots are to the left of the line is where the outcome is less likely for in the European groups. And I should also say that these findings have already accounted for differences in age, gender, initial blood pressures, deprivation, and a host of other medical and treatment factors. So we know that differences aren't been explained by any of those obvious differences in the characteristics of the sample. And if we start with the first outcome, which was how I chose to quantify hypertension detection. So it's whether after an initial raised blood pressure reading, the blood pressure was remeasured within 3 months. And you can see that that's slightly more likely in the South Asian than European groups. Then moving down, we can see that the likelihood of starting treatment was actually about 50% higher for the South Asian than European groups. And then differences in subsequent management, which again I operationalized in 2 different ways. So firstly, how many times in the first year of treatment the blood pressure was monitored. And secondly, whether the treatment was intensified if necessary. So by intensified, I mean if the blood pressure wasn't controlled by the initial medication, whether another medication was added or the treatment was switched or the dose increased. So it's whether a suboptimal blood pressure was reacted to or not. You can see that for the South Asian and European groups, those things were fairly similar, possibly a bit better for the intensification in the South Asian group. But if we look at the whole picture, the real standout differences here are in the use of antihypertensive medication. So both in persistence, i.e. which I measured by lack of gaps in treatment and in adherence, so how regularly people took their treatment throughout the first year, which were much lower in South Asian than European groups. However, slightly perplexingly, this didn't seem to affect blood pressure control after a year of treatment, which is shown by the bottom dot, which is sort of similar, if not a tiny bit better in the South Asia group. So now I've sort of superimposed the results for the African or African Caribbean groups on top here, which has shown the ethnic difference between the African Caribbean and European groups are shown in by the blue dots. So starting with the top two outcomes, you can see that detection was similar by ethnicity for these two groups, and the likelihood of antihypertensive initiation was actually about 50% higher as well for the African Caribbean than European groups. However, the situation gets a bit more dismal as we move down. You can see that the monitoring rate is lower for the African Caribbean group, and the likelihood of getting the treatment stepped up if needed is also a bit lower. But once again, the real standout differences or ethnic differences between these two groups were in persistence of treatment and the regular continual use of treatment. So about 50% less likely in the African Caribbean than European groups. And really, in some ways, the most important take-home message from this, this figure is that in terms of blood pressure control, the likelihood of meeting the target after 1 year of treatment was about 10% less in the African Caribbean than European groups. So what could explain this difference in blood pressure control? Well, I've said in the previous slide, if we look back here, that adherence was quite a lot lower in the African and African Caribbean groups and the European groups. So we decided to look at how control varied depending on whether people were adherent, i.e. took their medication regularly or not. And sure enough, for people who took the medication regularly, there was no difference in the likelihood of blood pressure control at a year between the African Caribbean and European groups, although the difference did remain for the non-adherent group. And this probably sounds quite obvious if you don't take the medication regularly, that the blood pressure is not going to be lowered as effectively. But in some ways, this was quite a radical finding, because it really goes against the idea that there's some intrinsic sort of biological or genetic difference between people, which explains ethnic differences in blood pressure control. And so if it's just because of lower levels of regular medication taking, then that's something we can do something about. I mean, for sure, we've got a lot of work to do improving healthcare engagement and trust in the medical establishment, tackling the reasons for all the different reasons people have for not adhering to treatment. But we've got something we can target and change through interventions. So just to summarise, for people of South Asian ethnicity, treatment initiation, monitoring and intensification was similar to or better than that in European groups, but regular continual antihypertensive medication was less less likely, and blood pressure control was similar. Whereas for people of African or African Caribbean ethnicity, treatment initiation was more likely, but regular monitoring and intensification were less likely than for the European groups, and regular continual antihypertensive use was less likely as well. Importantly, blood pressure control was worse than for European groups, and our results suggest this may be due to patterns of medication use. So future research should focus on reasons for non-adherence to antihypertensives in these three ethnic groups, and targeted potential interventions to address lack of adherence. Thank you very much for listening, and thanks to colleagues at UCL and also the School of Hygiene and Tropical Medicine. And thank you very much for funding the work to Diabetes UK, being my sponsors. Thank you. Thank you.
Thank you very much, Sophie, for that very interesting talk. Certainly, I mean, you know, you have identified an important, and you said really a very clear factor in explaining, or at least partly explaining, the differences in blood pressure treatment and control in the various races and ethnicities. So that really is very interesting. And now, for our participants, if you have questions for Dr. Eastwood, please type them in the Q&A function, and the speakers will answer your questions at the end of the 3 talks. So the next talk I'd like to introduce would be a talk by Dr. Natalie Creary. She is the founder of Liberating Knowledge, which is a knowledge and engagement consultancy. She's the program delivery director for Black Thrive, which is a partnership that addresses Black mental health. And Dr. Creary is going to talk to us about embedding co-creation for health equality, the health and racial justice labs in London. So without further ado, I'd like to call upon Natalie to give us her talk. Natalie, please.
Thank you, Bernard, and thank you for the invitation to share some of the work that I'm currently working on. So I'll just share screen. No, that's not what we're doing. Apologies. No. Hopefully this works. I will get there. Apologies. Okay, I've got the right screen now. Yay, we're winning.
Wonderful. Yes, wonderful. Thank you.
Okay, brilliant. So I'm here today to share with you a program that I've developed or developing in partnership with Healing Justice London, which has been supported by the Mayor of London. Okay, so when we're thinking about co-creation, I guess there's that question of like, why do we do it? Why now? And I think it's the sort of speakers that we've heard from already have kind of highlighted that health inequalities for racially minoritized groups persist, and for some health conditions they're widening. And I think that there's a recognition within the kind of health community that we don't have all the answers, and the recognition that there is value in lived expertise, and so that there is kind of a greater need for us to kind of draw on that expertise in order for us to kind of rethink the challenges that we are facing, but also in terms of what some of those interventions might look like. And we're increasingly seeing pockets of good practice, and there's really a sense that we kind of need to think about how that learning and the approaches that are working can be scaled and spread. So if I just give you a little bit of a background in terms of like how we arrived at Health and Racial Justice Lab. Well, I work in partnership with Healing Justice London, who are a kind of community-based organisation who are really focused on how we transform health systems and start to rethink about how we rebuild health infrastructures that are life-affirming for all. And so we responded to a tender that was put out by the Mayor of London that wanted to build the capacity of the workforce, and in particular focusing on community development approaches as a means of addressing health inequalities for London's communities. But both myself and the team at Healing Justice London have been working in this space for a number of years, and we recognise that, you know, increasingly that there is this kind of drive to kind of co-create, to co-produce, which is really positive, but actually these well-intended approaches can also be oppressive. And so really noticing that actually we can recreate the very systems that we're trying to dismantle and actually can create spaces that actually harm the communities that we are trying to serve. And similarly, we were reflecting on the fact that prior to George Floyd and the Black Lives Matter movement and the COVID pandemic, that actually for many of our health disciplines and health systems, we'd been silent on race and racism, and actually race was only actually really kind of considered as a variable in terms of kind of describing differences. And although that now that there is increasing recognition around racism, we know that this work is new for many, and actually there's a real lack of capacity and capability within the workforce in order to be able to drive this forward. And with that, there is also a reluctance from health systems and sometimes people working within these systems to really engage in anti-racism work. So we were trying to think about how we might be able to develop a programme that would help to address some of these challenges. So with the Health and Racial Justice Lab, I guess in some ways we are practicing what we preach, and what we're trying to do is co-create a methodology and to create space where people are able to work through uncertainty. Because when we're thinking about the work that we're trying to do in terms of moving anti-racism forward, actually we are trying to learn, develop, practice a way of being that for the vast majority of us is new, and we don't have the answers. And so a kind of key skill that we need to develop is that ability to be able to work through uncertainty, to be able to embrace experimentation, and to be able to experiment without shame, and when things go wrong. And that was one of the things that we really wanted to do. And for us, as I said, this is a learning process for all. So even as facilitators, we don't believe that we have all the answers. And actually what we are trying to do through this programme is to tap into the collective wisdom within the group. So the key aims for us is around how we can develop develop our understanding of the links between racism and health inequalities. We're working with our kind of cohorts to really look at how they galvanize the energies within communities, but doing it in a way that doesn't sort of replicate sort of white savior approaches, but actually genuinely kind of redistributes power. And so so a lot of our kind of methodology is around kind of provocation, and really trying to stretch our thinking, in particular around the things that we often sort of take for granted. We kind of recognize the power of the collective, and as I said, that we really want to sort of develop and build on the wisdom that's within the group, but also thinking about how we can work together in terms of using our levers for change. And I think another key point that we recognise that often in anti-racism work that is forgotten is that the importance of creating space for joy and healing. And this work is, it can be joyous, but it can be hard. And for us, we really think it's important that we prioritise self-care and community care, because this is going to be essential for us to be able to sustain ourselves over the long term. And again, the key area for us as well is around working systemically and supporting our cohorts to understand the inequalities that they are working to address in the wider context of systems of oppression, but also understanding the kind of historical context of why inequalities that people are observing exist. So some of the topics that we cover, as I mentioned, we look at the historical context that shapes health outcomes. We try to introduce concepts that are not ordinarily explored within kind of public health, in terms of like mainstream education, around kind of decolonization, abolition, and really kind of thinking about how these different concepts could actually both challenge but also enrich the work that we're trying to do. In particular around kind of critiquing and disrupting like the knowledge production process, as was heard in an earlier presentation, around the kind of the biological basis for the inequalities as being a narrative that has been persistent, but actually how we go about kind of disrupting that knowledge production process. And a key part is also about how we reimagine health systems. So rather than just kind of thinking about how we sort of tweak around the edges, but what would it mean if we were to build systems that were truly life affirming? What would they look like? And this is a sort of like process that we try to take our members along. And then I think the key part is the theory is great, but how do you then move that into action? So what difference have we made? Obviously, we're very much at our early stages of the programme, and you know, we've still got much more to learn. But I think some of the key things that are emerging from our work is that people are better able to understand the links between health inequalities and systems of oppression, that people feel that they're able to actually make change in the work that they're doing, which I think is kind of really important. I think some of the other things that, as I said, we're trying to expose people to kind of concepts that they may not ordinarily have come across. And so what we're also seeing is that people are now seeking out that information, but also people feeling more empowered and emboldened to be able to challenge within their kind of work places, but also in terms of supporting others who may be experiencing challenges within their work. So I think that some of the other things that we are kind of, and this is a kind of picture of a few of our members on one of our last sessions, but I think that the important thing about this kind of programme that's emerging is that people are, I suppose, more curious, more engaged, and there's a real energy in terms of actually putting that into practice. So some of the things that we've learned so far is that shifting our understanding and the narrative towards health and racial justice, I think, may be more helpful than just talking about inequalities. Because, and not that it's not important to talk about inequalities, but I think the kind of narrative around health justice, I feel, kind of creates a sense of, I suppose, a sense of urgency. It enables people to really understand health inequalities in the context of wider systems of oppression. And I think around working more systemically, we're seeing that there is a value in having space for people to share their experiences, to bring their wisdom, but also to find support from their peers. And a core part of our programme is about bringing people from different sectors together. So we have people from the community, private sector, voluntary sector, and all may not necessarily be working directly on health, but what we're trying to do is to highlight the importance of considering the wider determinants of health. And so actually everybody has a role to play. And what that has done has created and nurtured very, I suppose, more diverse and rich conversations, because we're looking at the challenge from very different perspectives. What we've tried to do also is to kind of create a space where the burden of anti-racism work doesn't fall solely on the people of colour, because that's often the case. And so we're really encouraging people who may not be racialised as minorities to really, I suppose, hold their own in the space and to, as you often said, like, do the work, but to do that in a supportive way. And what we're trying to create is one of the few spaces where people can come together, and I've made a typo, so apologies, but where we're kind of trying to create a space where there is no space for racism denial. And I think that is quite a different way of existing and working. And what we're trying to do is to encourage people who are on the programme to create that in their own workspaces. And as I said, we find that people are feeling more confident to be able to use their levers to make tangible change. And I just wanted to sort of end on a quote that came from one of our members from the first cohort, which I was personally quite touched by. And they said that I came in here thinking that change was decades away, but now I believe that it can happen every day. And I think this is one of the key messages that we're trying to communicate to our cohort members that often when we're working in the kind of racial and health justice space, we're thinking that, you know, change needs to be these huge, grand kind of changes, but actually sometimes it's the really small things that we do collectively that can really make tangible change for our communities on the ground. So if you want to hear any further information about it, you can email us at hrjlab at liberatingknowledge.com, and if you're London based, we have a programme that will be launching in January, and please do also follow us on, you know, the socials. Thank you.
Thank you very much, Natalie, for really very interesting talk. Now, after your talk, I now understand what you meant by co-creation and the Health and Racial Justice Lab. I mean, because as you said, it's you know, it involves a lot of empowerment and enabling people to find out more and to do something about the health, and also to address the health inequalities. So I think that's rather important, isn't it? That it's not just a system such as the NHS that, you know, address any inequalities, but also for people to, you know, to do more themselves, to find out more. The information is there, and especially for hypertension, the awareness and education means a lot, because doctors only treat the minor proportion of people who come to see doctors. What about the rest of the population? They need to be aware of, you know, hypertension. They need to have their blood pressure checked every now and then to seek treatment. So I think, you know, this empowering and as you said, you know, engagement of people is very, very important. So I think thank you very much for your talk. Now, we have got plenty of time for a Q&A. So I'm going to read out two questions from our audience. The first one is for Sophie. Can you please elaborate a bit on the concept of structural racism and its link to differential rates of cardiovascular issues in the racial groups referred to in your presentation? Sophie, please.
Yeah, sure. So, I mean, when we talk about structural racism, it's sort of an idea that racism permeates many different aspects of life and society. So not just limited to sort of overt examples of racism, like an insult on the street or whatever, but permeating to things like the lived environment, housing, education, healthcare, access to healthcare, all sorts of walks of life, and the criminal justice system, of course, as well, and the sort of effects of all those things in totality on people's health. So obviously those things, or some of those things, are difficult to measure, and how they impact you know, the body and the physiology is difficult to measure. But I'm happy to say there's a sort of growing literature about this in the US by is a woman called Nancy Krieger and Arlene Geronimus. They're both quite sort of eminent researchers in this area, trying to explicitly measure, particularly with regards to health inequalities between African and white Americans, how experiences of racism in all these domains could impact physiological systems, things like cortisol levels and blood pressure, stress response, and eventually track that to cardiovascular outcomes. So it's not that, unfortunately, at the moment, there hasn't been that much work in the UK in this area trying to link those two, but there's really some interesting work that's come out of the US on that.
Yes, actually, I've got a sort of technical question for you, Sophie. In your study, were you looking at mostly clinic blood pressure, or were they home blood pressure measurements? Because these two can be quite different. because, especially when it comes to compliance with treatment. So patients, when they know that they're coming back to or going to see a doctor, they start taking their medications. And for hypertension, that works. I mean, you can take the pill the day before or the few days before, and then your blood pressure comes down. Whereas for the rest of the time, it's not very well controlled. So home blood pressure readings are going to more useful than the clinic blood pressure reading. And in hypertension, we don't have the equivalent of a blood test like, in diabetes, like this, A1C, that can reflect the average reading over months. So, Sophie, so you're in your research, were you using clinic BP or home BP?
Yeah, for the I guess the most important outcome, which was the blood pressure control at 1 year, that was done with clinic readings. Yeah, but the NICE guidelines specify that you're supposed to sort of establish initial presence or absence of hypertension using ambulatory readings. So as far as we could, we used codes for that and thresholds so lower thresholds to establish hypertension. But yes, in terms of the most important outcome, it was just clinic readings, which is a drawback, as you say.
Yes. Well, I mean, if people only take their treatments intermittently, I think in some ways we all do. I mean, we all forget to take medications from time to time. That might be reflected in, for instance, target organ damage. So I think that may be a sort of long-term outcome to look at, whether there's any difference in target organ damage. Now, I've got another question from the audience for Natalie. Your work sounds quite revolutionary and interesting. What do you see as the next logical steps in taking your findings forward?
So we've only,
Natalie, please.
Yes, thank you. So I guess maybe it is. I don't necessarily see it as revolutionary. I think I start from the perspective of like what might be a potential solution. And I think in this space, I think, most people don't really understand the links between racism, not comfortable having those conversations, but then we're expecting people to like make change. And so I think that was what we wanted to do, was like, can we create a space where people feel more comfortable and able to have these conversations and to actually sort of test and trial different ways of working. So we're still kind of working out whether that actually happens. We're seeing it on a small scale. So I think we need to continue to kind of roll this program out and to wrap around some sort of solid research around it in terms of understanding the change that is happening. And I think one of the issues is it's quite difficult to find that or evidence the causal link, but it's something that we're certainly going to be working on. So we're only funded till the end of March, but by hook or by crook we'll continue.
Yes, I hope so too. It's certainly, your work sounds revolutionary to me. And as I said before the talk, I looked at, what on earth is co-creation and what is laboratory to do with it? Because for laboratory, I tend to think of, test tubes and other things. So I think, it's a very interesting initiative. And as you said, people don't like to talk about, racism, and people feel uncomfortable about this. I mean, both, the ethnic majority and also the ethnic minorities, everybody feels uncomfortable about, talking about this. Very often we like to pretend that nowadays there's very little racism, but as Sophie pointed out, there's also structural racism. I mean, things which are not just, a nasty comment on the streets, etc. So I think especially this structural or hidden, latent racism is also something one needs to address, especially if it impacts on health, because I think everyone is entitled to, health. Okay, now we have a third question. And I'm going to read this out. Has there been any work looking at more specific ancestral heritage in Africans, East versus West African descent, for example? there can be as much genetic variance between these groups as with Europeans. So basically, it is, you know, we perhaps we shouldn't just lump, you know, all Black people together. Should there be some differentiation, for instance, between East and West Africa? And I agree. I mean, you know, the difference is as much as between North and Southern Europeans. Natalie and Sophie, who would like to take this up?
Well, yeah, I mean, I suppose what we've got to be very careful is that when we're doing this research, that we don't try to reinforce the notion of a biological difference between different ethnic groups, because, yeah, it's really unhelpful. So I think, but what the differences that may occur may be as a consequence, as I refer to, like the wider determinants of health. So kind of social structures, the healthcare infrastructures that are present or not, as the case may be. So I think that these are just, yes, we're not all a monolith, and certainly in my work I think it's important to have like an intersectional approach, so where we're thinking about how our social identities might shape our experiences of health and illness and well-being, but again, those differences are often linked to what I describe as, what is described as systems of oppression. So it's racism, sexism, homophobia, Islamophobia. All of these things will be having an impact on people's health outcomes.
Yeah,
yes, I agree. I mean,
yeah.
yes. I mean, obviously there are genetic differences. Everybody has a different genetic background, but that's not, at the moment, they are not modifiable. So I think, I think as clinicians, we want to address, those modifiable risk factors, and those are really very modifiable, especially, the impact of, let's say, socioeconomic status, the impact of education, the impact of lifestyle, the diet and the amount of physical activity, both in their occupation, also in their leisure time. Sorry, Sophie, can I bring you into this discussion? Do you have any insight into this?
Well, yes, as Ed correctly says, and it's often quoted, there's more genetic variation between populations of African descent than there is, between African or European or Asian descent populations. So, so I'm not aware of any studies that have particularly looked at differences between East and West Africans in the UK, or people of those descent. I think that would be really interesting to do, partly more from a social perspective, though, in terms of the circumstances of migration, and obviously a lot of East African migrants from war-torn places in East Africa in more recent years, whereas the West African and Caribbean populations are a bit more older and well-established. So I think it'd be an interesting thing to do, but any differences I'd probably be inclined to, assign to social factors, socioeconomic factors, or psychosocial factors rather than genetic ones. Absolutely. I mean, just to elaborate one more point on what Natalie said, I think we do need to move away from this idea of race as biology. There's no reason why genes for skin color or other things to do with appearance should correlate with genes for disease. So yeah, that's all I've got to say.
All right. Now, whilst waiting for more questions from the participants, I actually have a couple of questions. I mean, Sophie mentioned, and Natalie too, about the biology, but we always tend to talk about genetics, genetic and environmental factors for diseases. And I think for hypertension, obviously both are important. And as I said before, there's nothing one can do to change one's genes. But what can, let's say, what can doctors, family doctors, general practitioners, what can they do more to reduce the inequalities? I mean, they're doing the best. I mean, they're measuring blood pressure, they are treating patients. Although there may be minor differences in their approach to, people from different backgrounds. But is there anything they can do, be more positive, be more proactive to reduce the health inequalities? Natalie and Sophie?
You want to go first, Natalie, or shall I?
I might need a little bit of a think, so if you wouldn't mind.
So Sophie first.
Yeah, I mean,
so what can your GP do, or the GPs in your practice do to address these health inequalities? I mean, there may be, at the moment they don't think there's any inequality, but your work shows that there are some inequalities. So what do you think they can do to reduce this?
Well, so I did highlight specific things that GPs, or some GPs aren't intensifying people's treatment as rapidly as they should. So I think there needs to be a bit more education, and that's actually. So it was worse for the African Caribbean groups in the study, but it's a problem overall with chronic disease management and this idea of therapeutic inertia, and treatments not getting stepped up in a timely fashion. So I think more education about that and more encouragement is important. I think with the adherence story, again, there's not much research in the UK about why there should be ethnic differences in that. But here's an area where the US is ahead of us again. And there is a strong suggestion of mistrust in the medical establishment, which we saw obviously that there's a much more vaccine hesitancy in South Asian and African Caribbean groups in the UK around the COVID vaccine. So I think we need to build trust again with these communities, and one of the ways of doing that is to have situations where you're not trying to, as a GP, you're not trying to get people out the door in 5 minutes, and you've got appropriate time to spend with people, and address their concerns properly. Continuity of care, being able to see the same doctor that you build a rapport with and trust. So some of this is a symptom of the fact that the healthcare system's, in dire straits at the moment anyway. But I think that there must be ways, and I'm sure Natalie will be able to speak to this much better than me, of sort of trying to connect and re-establish or establish trust, and giving people that time and making them, being able to motivate them to take treatment for what at the end of the day is usually a risk factor state with no symptoms. So yeah, I'd be interested to see what if you've got what you can add to that, Natalie. I'm sure you've got some nice insights.
Yeah. So I would agree. I think it's important to listen, and I think that there is sometimes the way in which people from racially minoritized group might express pain, their conditions, for example, there needs to be, I suppose, improving the kind of cultural capability, I think, of the workforce is key. I think also when people may not be adhering, it's like, what is the response? Are you being told off? But actually you may have a very complex life, and therefore, or working very long shifts and things like that may make it difficult for you to adhere to your medication. So rather than being chastised for not following it, it's how can you better understand what is going on for you that makes it difficult for you to adhere to your medication. I think that there is also something about also being more open to how you can integrate kind of traditional medicine. So I think sometimes people from racial minoritized communities may feel that actually, unless it's kind of, if they were to kind of use those types of treatments, that they would be kind of looked down upon by their clinician. So I think that there is also something in that I think can also help around the adherence story.
Yeah.
Oh, yes,
I mean,
I think that there's several interesting points there, such as, complementary or traditional medicines. I mean, surveys repeatedly show that, our patient, I mean, a good proportion of patients, maybe, I don't know, maybe 40% or something like that, will resort to, complementary and traditional medicines. And very often they don't, as you said, they might not want to tell their GPs. Yes, for fear of being told off.
Yeah.
Oh, sorry, Sophie, you have something to say?
But just picking up on Natalie's point, one really key thing about our work on hypertension and diabetes is that the South Asian and African Caribbean groups are, 5 to 10 years younger at onset of treatment than the white groups. And then you get people sort of my age, mid-40s, with a, double burden, looking after kids, trying to work, aging parents. And I think that it is also a key reason for sort of lower levels of adherence in these groups. But again, these are things that can be worked around, I believe. So
yes. Well, I think another point that I want to take up from Sophie's answer earlier is about the work in the US. I have contributed a little bit to that work, and it was found that, for instance, in the US they have a sort of Spanish-speaking Hispanic community, which which there isn't in the UK. So if you have information sheets which are printed in Spanish, then those Spanish-speaking people may feel, that that's more relevant to them rather than, everything, all the information in English. So, so again, that's something to think about, is to, to have health information delivered in, not just in English, but in other, languages as well. So people, ethnic minorities may then feel that, that the advice, the health advice there would apply to them, rather than to the general population, and they might feel that, that they are different, and those advice may not apply to them. So that's also something to think about. And especially nowadays, with electronic information, it's very easy to deliver any messages in multiple languages. So that's also something to think about.
Yeah.
Yes. Right. Is Dr. Ahmed still with us, or because I think it'd be lovely if we have we can ask him a question. If not, well, can I invite some final comments, first from Sophie and then from Natalie?
yeah,
Some closing comments and advice from Sophie, and then from Natalie.
I think so. My take on things is to move away from the biological models of ethnic differences in disease, and try and focus more on empowerment. I think is really important, and trying to not sweep racism under the carpet, be it structural or more overt, to tackle it head on and recognise the contribution it's made to health inequalities in the UK. And adherence is really important.
Yeah, so
Natalie?
I certainly would agree. I think we need to become more sophisticated, I think, in being able to understand and identify, in particular, racism in terms of structural racism and how that shapes health outcomes and the work that we do and why we do the work that we do, and how we also kind of are sometimes complicit and actually contribute to kind of upholding the status quo. And I think being more honest about that. I think it will help us to make strides in that. And I think in particular around when we're thinking about the health system in the NHS in particular, because that's the context that I kind of exist in, is the elephant in the room is around racism and bullying in their own workplace. So if you cannot be good to your team members, how on earth are we going to expect anything, better for the communities that we serve? And in somehow there is a division between, or separation between, Black, Asian and minoritized groups who work for the NHS as somehow being separate from the population, and they're not. And so I think that is, I think if we could do anything for kind of focusing on addressing bullying, racism and harassment in the NHS would mean that we'd make strides in addressing inequalities, I think.
Thank you, Natalie. Now, before we close, I'd like to draw our participants' attention to the next webinar on healthy inequalities, which is going to be on women's health, and it's going to take place tomorrow. Please register, and even if you can't attend the webinar in real time, if you register, you receive the recording of the webinar. And also, we encourage you to tweet about these webinars using the hashtag World Healthy Life hashtag. Okay, so finally, I would like to thank Shahed, Sophie, and Natalie once again for your excellent talks, and very, very thought-provoking and also very positive. I think, I can come away from this webinar now, have a very firm agenda in my mind, very practical things we can do to improve cardiovascular health in our community, which after all is the aim of the Healthy Heart Trust. So thank you, all of you. Thank you, and good evening.